Hi, everyone. Welcome to our first CanVector National Thrombosis Seminar of the year. My name is Joseph Shaw. I'm a hematologist and thrombosis medicine specialist from the Ottawa Hospital. We have two really fantastic speakers lined up for the seminar today, Dr. Stephanie Carlin from McMaster University and Dr. Ton Lisman from the University of Groningen. So just some reminders here, the CanVector National Thrombosis Seminars, these are monthly seminars that will be hosted live throughout the academic year featuring state-of-the-art thrombosis or VTE lectures presented by both Canadian and international experts. Recordings of these seminars will be available online at canvector.ca after the seminar itself. And just a friendly reminder that these seminars are self-approved group learning activities as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. So this is the CanVector Planning Committee in terms of the national seminars. I'm the chair of the committee and I'll be the moderator today. And you can see the other members of the committee here. So today's presentation is going to be on thrombosis and anticoagulation therapy in cirrhosis, current guidance and future research needs. And I'll introduce our two speakers today. So Dr. Ton Lisman is a biochemist with a profound interest in translational clinical research. He received his PhD at the Department of Hematology from the University Medical Center Utrecht in the Netherlands on a thesis on the mechanism of action of recombinant coagulation factor 7 in 2002. Since 2007, he works at the Surgical Research Laboratory and the section of hepatobiliary surgery and liver transplantation at the Department of Surgery of the University of Groningen in the Netherlands. He was appointed full professor of experimental surgery in 2015. He serves as co-editor-in-chief for the Journal of Thrombosis and Hemostasis and leads the ISTH-SSC subcommittee on hemostatic management of patients with liver diseases. His research interests include hemostatic changes in liver disease and liver surgery, the role of hemostatic components in damage and repair of liver tissue, and the role of the fibrinolytic system in thrombosis. Now, these topics are studied in close collaboration with local and international clinical partners, which includes surgeons, hepatologists, hematologists, intensivists, and anesthesiologists. Dr. Stephanie Carlin is a thrombosis pharmacist at Hamilton Health Sciences and assistant professor in the Division of Hematology and Thromboembolism in the Department of Medicine at McMaster University. She completed a Bachelor of Science in Pharmacy at the University of Toronto in 2010, followed by a Doctor of Pharmacy at the University of Florida in 2015. She then completed a general practice pharmacy residency, followed by a specialty practice pharmacy residency in thrombosis, both at the University of Toronto. In addition to her clinical and teaching activities, she is actively involved in venous and arterial thrombosis research with an interest in anticoagulation in special populations, including liver diseases. She co-chairs the ISTH-SSC on hemostatic management of patients with liver disease and recently published a guidance document on anticoagulation for stroke prevention in atrial fibrillation and treatment of venous thromboembolism and portal vein thrombosis in cirrhosis, which I think is going to feature during their presentation today. So the learning objectives during the seminar today are so after the seminar, participants will be able to describe the effect of liver disease on primary and secondary hemostasis and fibrinolysis, review highlights from the recent ISTH-SSC guidance document, anticoagulation for stroke prevention in atrial fibrillation and treatment of venous thromboembolism and portal vein thrombosis in cirrhosis, and then discuss unmet research needs in thrombosis and anticoagulation in the context of liver disease. Just a friendly reminder, so the two speakers will present, and then after both presentations, there will be a 15-minute Q&A period. So if you have questions, you can put them in the Q&A section, and then I'll go over them at the end of both presentations. And with that, I will hand over to Dr. Lisman and Dr. Carlin.
Thank you very much. Good morning, everyone, and thanks for the invitation to speak here this morning. So what I will do is talk to you about hemostatic changes in patients with liver disease and the consequences and the interesting but also complicated thing in patients with liver disease is that they may experience both bleeding and thrombotic complications. So I will cover some of the bleeding complications, and in the second part of this seminar, Dr. Carlin will discuss thrombotic complications. So these are our disclosures. So the liver really plays a central role in the hemostatic system because it's the site of synthesis of almost all proteins involved in the hemostatic system. So the liver makes coagulation factors, but also proteins involved in inhibition of coagulation. The liver makes proteins involved in clot breakdown, and the liver makes thrombopoietin, which is the hormone that produces platelets. So in patients with advancing liver disease, and if liver synthetic function becomes compromised, um, the plasma levels of these proteins go down, as shown in the next slide. So patients with liver disease experience a wide array of hemostatic alterations that include thrombocytopenia, but also defects in platelet function, although these platelet functional defects are not very well defined. There's low plasma levels of coagulation proteins, but also of inhibitors of coagulation, low plasma levels of proteins involved in fibrinolysis, in clot breakdown. And there's elevated levels of a discrete number of proteins that are not synthesized by hepatocytes, but are rather synthesized by endothelial cells. And these proteins include, for example, formalin factor and factor VIII. So my laboratory has been interested in the consequences of all these hemostatic changes for the clinical phenotype. So what you see in the diagnostic laboratory are clear changes: a low platelet count, prolongations in routine clotting tests, including the prothrombin time and the APTT. And the combination of these changes in diagnostic tests are really suggestive of a bleeding tendency. And so historically, these changes have been interpreted as a hemostatic-related bleeding tendency. And this bleeding has been really evident, and it's still evident. And here's a quote from a paper from a long time ago, but I think this illustrates how we got to the theory that liver disease is accompanied by a hemostatic-related bleeding tendency. So this is a quote from a paper. Please go back. Well, yeah. From a paper from Pittsburgh, which was one of the centers that pioneered liver transplantation. And so in the early years of liver transplantation, so in the 1980s, bleeding really was an issue. And this was a report from the first 5 years of the liver transplant program in Pittsburgh. And the report in just over 600 patients, a blood transfusion in total of 18,000 red cell units, 23,000 FFPs, and 20,000 platelet units. So on average per transplant, there was 30 units of packed red cells, 40 units of FFP, and about 30 units of platelets. So this was an enormous amount of blood products. So you can imagine that these patients, they lost multiple times their circulating blood volume. So this combined with the alterations in the hemostatic tests really suggested that the hemostatic. Excellent. Apologies. Yeah, I had a Wi-Fi failure. I still have, but I'm now on 4G. So I was talking about major blood losses during liver transplantation in the 1980s, and that changed completely over time. And these are recent data actually from a group in Canada that actually reports that more than 75% of their patient can receive a liver transplantation without the requirement for any blood product transfusion. So in this paper that reports 700 consecutive patients, so this is a large series, the mean red blood cell transfusion was half a unit per patient. And this contrasts, of course, tremendously with the 30 units reported back in the 1980s. So apparently we can do much better. And the observation that we can do a liver transplant without major blood loss, without requirements for major blood transfusions, really suggests that the prolongations in the prothrombin time and the thrombocytopenia might not directly translate into a bleeding tendency. So bleeding during liver transplantation decreased tremendously. Please go back one slide. But there's other bleeding complications that are still there. And I think one of the very important things that we learned is that some of the bleeding complications seen in patients with liver disease are there. Quite good evidence that alterations in the hemostatic system do not play a role here. So, for example, if patients use anticoagulants at the time of the variceal bleed, they don't bleed more compared to patients that do not use anticoagulants at the time of the variceal bleed. So, portal hypertensive related bleeds are common and can be very severe. And a second type of bleeding that's very common is bleeding due to mechanical issues. So blood vessels can be damaged during surgery, but also during more minor invasive procedures that commonly occur in patients with liver disease. And if you accidentally injure a blood vessel, bleeding occurs, but this is not bleeding because of hemostatic failure. There are bleedings that are a consequence of hemostatic failure that are shown here on the right-hand side of the slide. For example, bruising, bleeding after venipuncture, bleeding after dental extractions. And these are likely related to defective hemostasis. But it's very important to realize that all these bleeds are relatively minor, usually self-limiting, and very, very seldomly require hemostatic interventions. So even though bleeding due to hemostatic failure occurs in these patients, it's not very severe. Next slide, please. One of the other major concerns that have always been around in patients with liver disease is the concern for bleeding during invasive procedures. And so there was always the thought that if you would do a major or a more minor invasive procedure, that bleeding risk was high. However, if you quantify this, it's really not as bad as one would think. This is a recent prospective study quantifying bleeding risk after common invasive procedures in patients with liver disease. So this study that took place in North and South America included more than 1,000 patients and more than 3,000 procedures. And the risk of major bleeding was only 0.9%. And this, I think, was much lower than was commonly anticipated in the field. So there really was a different perception of bleeding risk during procedures than was actually there. Next slide, please. So not only is bleeding rare, and if bleeding occurs, it's like I said, often unrelated to hemostatic failure, but it's also not related to these laboratory abnormalities that we see. So bleeding in patients with liver disease is not predicted by abnormalities in the perfusion time or INR or the platelet count. And there's quite good evidence. So this meta-analysis on the risk of bleeding as a function of the INR, and that really showed that patients that have a normal INR bleed just as much or just as little as you wish as patients with an elevated INR. And the same is true for platelet count, although the literature is less convincing there. Next slide, please. So these clinical observations, together with laboratory observations that I will share in a minute, have led to guidance that may be considered counterintuitive and to some maybe even controversial. But this is guidance issued by the ISTH. But the language is very, very similar in guidance documents issued by other large international societies, including the European Association for the Study of Liver Disease and the American Association for the Study of Liver Disease. So in our guidance document, we state that routine diagnostic tests of hemostasis, so prothrombin time, APTT, platelet count, and fibrinogen, should not be routinely evaluated to predict bleeding prior to procedures in patients with cirrhosis, even in those that are critically ill and really have abnormal routine diagnostic lab test results. So we really advise not to measure at least not with the aim to predict bleeding risk, because these tests do not predict bleeding in these patients. And so then we also recommend against prophylactic correction of these abnormal tests. So we can accept elevated prothrombin times or APTTs, and we can accept thrombocytopenia in these patients. And we shouldn't treat abnormal laboratory values prior to invasive procedures. So what's now the mechanistic explanation for these recommendations? And so this slide really summarizes 15 or 20 years of laboratory work by multiple laboratories in Europe and North America mainly. And all these laboratory studies really have led to the concept of rebalanced hemostasis. So what happens in patients with advancing liver disease is that there are simultaneous changes in pro and anti-hemostatic mechanisms. So there are changes that promote bleeding, and at the same time, there are changes that promote clotting. And so these simultaneous changes both occur in primary hemostasis. So there's decreases in platelet count and maybe in platelet function that are balanced by highly elevated levels of the platelet adhesive protein forwardment factor that really in model systems has been shown to really be a compensatory factor here. Similarly, decreases in procoagulant factors are balanced by decreases in anticoagulant factors, and decreases in antifibrolytic proteins are balanced by decreases in profibrolytic proteins. So in essence, there's a reset of the hemostatic balance in patients with liver disease, shown on the top of this slide. And the only difference between liver disease patients and liver healthy patients or liver healthy individuals is that the weight on both ends of the hemostatic scale is less in patients with liver disease, which may suggest that the balance in patients with liver disease is less stable, which may explain why these patients may both clot and bleed. Next slide, please. So this is just one example of the many, many laboratory studies that have led to this concept of rebalanced hemostasis. And this particular experiment actually hints towards the thrombotic risk of patients with liver disease. So these are thrombin generation experiments in vitro in plasma from patients with liver disease. Here they are split according to the etiology of liver disease. So patients with cholestatic disease, with fatty liver disease, alcohol-related liver disease, and viral liver disease. And these thrombin generation experiments are performed in the presence of thrombomodulin, which is the activator of the anticoagulant protein C system. And I think that thrombomodulin modified thrombin generation really is an honest representation of the hemostatic balance, because it's a test that is sensitive for all pro and anticoagulant factors. And this is in contrast to the prothrombin time, which is a test that is only sensitive for procoagulant factors and not for anticoagulant factors. So if you do thrombin generation tests in these patients, you can appreciate that these patients generate as much or perhaps even more thrombin compared to controls. And the controls are here on the right-hand side of the graph. And these patients that make more thrombin than healthy controls may be those patients that are at risk for thrombotic disease. So summarizing what I've just told you is that the sort of historic concept that liver diseases are associated with a bleeding tendency that is ascribed to defective hemostasis is really no longer valid. There is bleeding in patients with liver disease, but this is largely unrelated to hemostatic failure. So the treatment of bleeding in patients with liver disease really is different from pro-hemostatic treatment. The treatment is much more directed either towards treatment of portal hypertension or towards local treatment of injured vessels. And finally, patients with liver disease are not auto-anticoagulated, so they're not protected against thrombotic disease, but they are in a relative hypercoagulable state that may predispose them to thrombosis. So with apologies again for the interruption, I thank you for your attention. I hand over to Dr. Carlin.
Okay, Thank you very much, Dr. Listman, for that excellent background and introduction. And thank you very much to the group at CanVector for inviting us to speak to you today. So with that, I'm going to jump into the next section of the presentation, which is essentially going to be a summary of our latest guidance document published at ISTH entitled Anticoagulation for AFib, DVT-PE, and portal vein thrombosis in cirrhosis. So there's, of course, a number of factors that make anticoagulation quite challenging in patients with cirrhosis, much of which you just heard about from Dr. Listman's presentation. So our guidance document attempts to answer which population should be anticoagulated in the context of cirrhosis, which antithrombotics should be used, at what dose, and how long should they be treated for. So I'm going to, throughout the rest of the presentation, attempt to answer these questions. So starting out with the question of which antithrombotic, each of the different options as far as anticoagulation, as you can imagine, have their challenges when used in patients with liver disease and can have altered both efficacy and safety. First, when it comes to low molecular weight heparin, as you heard, patients with cirrhosis have reduced production of antithrombin. And of course, low molecular weight heparin is reliant on binding to antithrombin, so this could result in an altered anticoagulant effect. Further, in patients with more advanced disease, volume overload and hepatorenal syndrome can affect drug absorption, distribution, and clearance. And the long-term use of low molecular weight heparin, of course, is challenging as well due to patient adherence, discomfort with regular injections, as well as the cost. There's significant historical experience with the use of vitamin K antagonists in general and in patients with liver disease. However, they have a number of challenges associated with their use as well. Patients with cirrhosis, again, as you heard, have reduced factor levels, reductions in plasma proteins, altered hepatic blood flow, hepatic enzymes, and biliary clearance. So all these factors can affect drug distribution, metabolism, and clearance. Another challenge with vitamin K antagonists is that the usual target INR ranges that we would use in patients without cirrhosis may not be appropriate in those with cirrhosis who have elevated baseline INRs. And finally, in terms of direct oral anticoagulant use, the use of these agents is, of course, increasing in general and in patients with liver disease. However, there's challenges with their use as well, including the fact that patients, again, with cirrhosis have reduced factor levels, plasma proteins, and again, altered hepatic blood flow, hepatic enzymes, and biliary clearance. They may also have hepatorenal syndrome and more end-stage disease. And again, all of this can affect drug distribution, metabolism, and clearance. So the first indication for anticoagulation in liver disease that we're going to discuss is atrial fibrillation, which, as you know, is one of the most common reasons for anticoagulation in general, and also in patients with liver disease. There's a significant burden of atrial fibrillation in patients with liver disease with about a 5% prevalence. And there's increasing prevalence with increasing severity of disease. So in patients with a MELD score of less than 10, the prevalence is about 4%, but this increases to above 20% in patients with scores above 30. The increased risk of atrial fibrillation in liver disease is attributable to various shared risk factors, including hypertension and obesity, complications of disease, including cirrhotic cardiomyopathy and hepatorenal syndrome, as well as the treatments for complications of cirrhosis, including the use of diuretics, lactulose, and antibiotics, which can contribute to hypovolemia and electrolyte imbalances and the risk of atrial fibrillation. Importantly, the risk of ischemic stroke and death in patients with atrial fibrillation and cirrhosis is increased as compared to those without liver disease. And you can see the odds ratios listed here on your slide. So if atrial fibrillation is associated with increased harm in patients with liver disease, can we reduce the risk of stroke and death without significantly increasing the risk of bleeding in a population who may be at risk for bleeding? So this table summarizes the results of a meta-analysis followed by the results of 3 more recent cohort studies, assessing the benefits and risks associated with anticoagulation compared to no anticoagulation for the indication of stroke prevention and atrial fibrillation in liver disease. So overall, you can see that anticoagulation either with warfarin or with DOACs is associated with significant reductions in risk of stroke and mortality, with no signal for an increased bleeding risk. However, this data is limited to observational studies, which included patients with primarily lower MALD or Child-Pugh scores, with the exception of the final study here, which included patients with Child-Pugh C cirrhosis, but this is published only in abstract 4. And we know, of course, that observational studies are at significant risk of bias, so it's likely that those who were at highest risk for stroke and lower risk for bleeding were the patients that clinicians chose to anticoagulate. So what about comparing the use of DOACs versus vitamin K antagonists for stroke prevention in atrial fibrillation in patients with liver disease? So this table summarizes the key observational studies addressing this question. It includes 4 cohort studies, as well as a meta-analysis, which is the Menicelli study. The evidence that we have suggests that DOACs are similarly or more effective than warfarin as far as the prevention of stroke and atrial fibrillation, as well as the prevention of death. And they appear to be associated with a lower risk of major bleeding, including intracranial hemorrhage. Again, however, all of the studies, except for the last abstract, Ayub et al. Here, included patients with lower MALD or Child-Pugh scores. And so we have to sort of take this information with a grain of salt. The pharmacokinetic and dynamic evidence that we have supporting the use of specific DOACs in liver disease is currently limited to small in vitro or in vivo studies. The results that we have highlighted in pink here indicate where there is an increased anticoagulant effect in cirrhosis, whereas the results in yellow indicate a lesser anticoagulant effect. Results that are starred here are results that are derived from in vitro rather than in vivo studies. So going through the different DOACs here, when we look at dabigatran, despite it having the lowest hepatic clearance of all the DOACs, the data that we have available pharmacokinetically and pharmacodynamically suggests that there's a possible excessive anticoagulant effect in cirrhosis. You can see that there's progressive reductions in ETP with increasing Child-Turcotte-Pugh scores, and a greater increase in INR in patients with Child-Turcotte-Pugh B scores. When we look at rivaroxaban, there is also a possible altered anticoagulant effect in patients with cirrhosis, particularly those with moderate disease. You can see that in Child-Turcotte-Pugh score B, patients do have greater increases in INR with use of rivaroxaban. However, on the contrary, we do see lesser reductions in ETP from an in vitro study. As far as apixaban goes, there's likely similar or reduced anticoagulant effect in cirrhosis. Overall, the study suggests similar drug exposure in patients with Child-Turcotte-Pugh A and B patients as compared to controls. However, you can see here that there was lesser reductions in ETP in one in vitro study. And then finally, when we look at edoxaban, there may be a possible altered anticoagulant effect in cirrhosis. You can see the greater increases in INR and anti-10A levels in patients with various levels of disease. However, one study did find a lesser decrease in ETP with advancing disease. Moving on to the clinical outcome data that we have, this study compares rivaroxaban with apixaban in patients with atrial fibrillation and chronic liver disease. So what you can see in this study here is that there was a trend towards an increased risk of stroke with rivaroxaban as compared to apixaban, as well as a statistically significant increased risk of major bleeding and specifically major gastrointestinal bleeding with rivaroxaban as compared to edoxaban. Similarly, in this study by Duros et al., again comparing apixaban to rivaroxaban, the authors found no significant difference in the rates of ischemic stroke between groups, but there was a lower risk of major bleeding with apixaban as compared to rivaroxaban. And then when these authors specifically looked at the subgroup of patients with cirrhosis, they found similar findings of a lower risk of major bleeding in patients with receiving a lower risk of major bleeding in patients receiving apixaban versus rivaroxaban, although this wasn't statistically significant, likely due to the lower numbers of patients with cirrhosis enrolled in this study. So having gone through the available evidence, what did we recommend in our ISTH SSC guidance document? So we recommended that patients with Child-Pugh A or B cirrhosis and atrial fibrillation with a CHA2DS2-VASc score of 2 or greater in males and 3 or greater in females be anticoagulated for stroke prevention. And this is consistent with the cardiology guidelines in patients who do not have cirrhosis. We made a lower grade recommendation, so a suggestion that patients with Child-Pugh A or B cirrhosis with lower CHA2DS2-VASc scores, so 1 in males and 1 or more in males and 2 in females, be anticoagulated for stroke prevention. Again, this is consistent with what is recommended in the cardiology guidelines. And then we suggest that DOACs at standard doses are used in patients with AFib and Child-Pugh A or B cirrhosis in preference to vitamin K antagonists. We found that there was inadequate clinical or pharmacokinetic evidence to recommend for or against specific DOACs. And then finally, we suggest a case-by-case consideration of referral for left atrial appendage occlusion in select patients with atrial fibrillation and cirrhosis at high risk for stroke who are not candidates for or who have failed anticoagulation and who are expected to have a reasonable life expectancy to benefit from this procedure. So this could, for example, include a patient who is awaiting liver transplant. So moving on now to anticoagulation for VTE in patients with liver disease. So we know that there's an increased risk of VTE as well as 90-day all-cause mortality after VTE in patients with cirrhosis as compared to those without. Patients with chronic liver disease are less likely to receive anticoagulation. 37% filled a prescription for an antithrombotic after a diagnosis of VTE as compared to 77% of patients without cirrhosis in one observational study. There's limited data on the optimal choice of anticoagulant in liver disease. The Einstein and Hokusai studies looking at rivaroxaban and edoxaban in VTE excluded patients with cirrhosis. Similarly, the Amplify study looking at apixaban excluded patients with active and clinically significant liver disease. They didn't specifically have a cirrhosis criteria exclusion. And then finally, the Recover study looking at dabigatran excluded patients with liver disease with liver enzymes greater than 2 times the upper limit of normal. They didn't have a specific exclusion criteria for cirrhosis. So what have we recommended in our ISTH SSC guidance document? Well, we recommended that patients with cirrhosis and acute DVT or PE are offered anticoagulation, barring a contraindication to use. Similar to what would be recommended in patients without cirrhosis. We suggest the use of either a DOAC or a low molecular weight heparin to bridge to a vitamin K antagonist for patients with Child-Pugh A or B scores based on patient preference. We didn't specifically recommend one weight agent or the other, just based on limited evidence supporting one over the other in this specific population. We suggest low molecular weight heparin use alone or as a bridge to vitamin K antagonists in patients with a normal baseline INR, in those with Child-Pugh C cirrhosis. And then finally, we suggest that anticoagulation not be withheld in patients with moderate thrombocytopenia that's secondary to liver disease. And once the platelet count drops below 50, a case-by-case decision should be made based on the site and the extent of thrombosis, the risk of extension, and considering patient preference, as well as presence of active bleeding or additional bleeding risk factors. So moving on to our last topic, that is portal vein thrombosis and the anticoagulation of this disease in patients with cirrhosis. On the left-hand side of this screen here, you can see the portal vein, which, as you know, drains blood from the gastrointestinal tract and the spleen into the liver. This, of course, differs from the hepatic vein, which drains blood from the liver into the IVC. So in terms of a brief review of our pathophysiology of portal vein thrombosis, liver fibrosis leads to portal hypertension. This leads to enlargement of the portal vein and formation of portosystemic collateral vessels. The increase in portal vein diameter and the steal effect from these collateral vessels ultimately leads to a reduction in portal blood flow and risk of portal vein thrombosis. The risk of portal vein thrombosis can also be increased secondary to endothelial dysfunction from the portal hypertension, as well as from bacterial translocation. And then this can induce endothelial expression of von Willebrand factor and factor VIII, increasing the risk of thrombosis. Portal vein thrombosis in cirrhosis, as you probably know, is quite common. It is often asymptomatic, and it's often identified on screening investigations, for example, in patients presenting with decompensated disease or for hepatocellular carcinoma. When we look at studies indicated on the right-hand side of your screen of patients with, sorry, just 1 second. Apologies, it's just a code blue announcement there. So when we look at the studies looking at incidence of portal vein thrombosis in patients with cirrhosis, and we look specifically at those that include larger numbers of patients with more advanced disease, that is Child-Pugh scores, you can see that the incidence of portal vein thrombosis is as high as 25% here. Portal vein thrombosis is, of course, important because it can be associated with a number of complications, including worsening of portal hypertension associated bleeding, and in patients who are candidates for liver transplant can be associated with worse transplant outcomes. So moving on to anticoagulating patients who have portal vein thrombosis in the context of liver disease. So we know that anticoagulation, particularly in chronic asymptomatic portal vein thrombosis and liver disease, is associated with improved but still low rates of recanalization. In patients who are anticoagulated, about 59% will recanalize versus 21% without anticoagulation. A recent individual patient data meta-analysis in patients with cirrhosis and portal vein thrombosis found a survival benefit with the use of low molecular weight heparin or vitamin K antagonist use, independent of whether patients had, independent of whether they recanalized their portal vein. And you can see the hazard ratio for all-cause mortality, 0.59. However, this did come at the cost of some increased risk of non-portal hypertension related bleeding, about 10% versus 2%. As far as the DOAC data, it's really limited to small cohort studies and meta-analyses of these small studies. The available data does suggest improved recanalization as compared to warfarin with no increased risk of bleeding. So what do the previous guidelines prior to our ISTH guidance statement recommend about the treatment of portal vein thrombosis in the context of cirrhosis? You can see overall here that there's consistent recommendations for patients to receive anticoagulation in the context of recent or progressive portal vein thrombosis. When it comes to more chronic portal vein thrombosis, the recommendations are more variable, with consideration given to whether patients have additional risk factors or whether they are going to be candidates for liver transplant, because as I mentioned, their outcomes can be poor if they have a portal vein thrombosis. All of the guidelines here endorse the use of either low molecular weight heparin or vitamin K antagonists. And the newer guidelines published in 2021 and 2022 also support the use of DOACs. So what have we recommended in our guidance document? Well, we have said that we recommend that all patients with cirrhosis and symptomatic portal vein thrombosis be treated for a minimum of 6 months. We suggest that anticoagulation be prescribed for all patients with cirrhosis who have asymptomatic but progressive portal vein thrombosis, unless there's clear contraindications to anticoagulation. We recommend continuing anticoagulation for all patients with cirrhosis and portal vein thrombosis who are going to be candidates for liver transplant. We have said that anticoagulation may be considered in patients with cirrhosis and asymptomatic portal vein thrombosis who are not candidates for liver transplant. This would be on a case-by-case basis. And the rationale here is that based on the data that I showed you previously, anticoagulation may be associated with survival benefit. And then finally, we recommend evaluating for the presence of varices and ensuring adequate management of those varices prior to initiation of anticoagulation therapy. So in summary, anticoagulation in liver disease is challenging. There is an increased prevalence of atrial fibrillation, DVT-PE, and portal vein thrombosis with poor outcomes in patients with cirrhosis. We know there's an increased risk of stroke in patients with atrial fibrillation and an increased risk of mortality in patients with VTE. We know that anticoagulation in the context of atrial fibrillation reduces the risk of stroke and death in patients with mild to moderate disease, with DOACs being equally effective as vitamin K antagonists with a reduced risk of major bleeding and intracranial hemorrhage. And then anticoagulation in portal vein thrombosis improves recanalization and may also increase survival. Overall, in this population, however, there is limited data for DOAC use. So with that, I'm going to hand it back over to Dr. Lissman.
Thank you very much. So although we now clearly established the problem that the patients with liver disease really are at risk for various thrombotic diseases, we have very little data on how to treat them. So we've listed a number of future research needs that we think need to be addressed. So one regards not thrombosis, but bleeding. Our recommendations to not treat abnormal coagulation tests with infusion of plasma and FFPs in practice are not really followed. So we need strategies to improve adherence to our guidance documents, because we think these unnecessary transfusions may do harm. In terms of what needs to be done in the thrombosis arena, is that we need to better understand which patient benefits from a prophylaxis. If patients benefit from a prophylaxis, there are some studies that have shown that thromboprophylaxis does not increase risk of bleeding, but also does not decrease the risk of developing venous thrombosis, which suggests that we might be using anticoagulants wrong, that we might be dosing anticoagulants wrong, or that we are treating the wrong patient population. There's a clear need for data on efficacy and safety of DOACs for treatment of portal vein thrombosis in cirrhosis, but also for the other indications. It needs to be established what the optimal DOAC is. There's still an issue with how we anticoagulate patients with more advanced disease, so with Child-Pugh cirrhosis. There's very little data, and there's an increased risk of portal hypertension-related bleeding in these patients. So this makes this a clinical dilemma of what to do. We've discussed potential alterations in anticoagulant effects of the different anticoagulant drugs. So dose adjustments may be required, and they need to be studied also clinically. And I think there's an interest in the liver field also for the new generation anticoagulants, so inhibitors of 11 and 12 that are potentially safer in terms of bleeding risk, which might be a particular benefit in these patients. And then finally, there's this interesting concept of using anticoagulation to decrease disease progression and eventually decrease mortality. And we need more data to really ascertain that this is a real valid concept, and that we need to explore this clinically. So finally, we have joined ourselves in an SSC subcommittee of the ISTH that was started not too long ago. And if you're interested in this topic, and if you're a member of the ISTH, please join this SSC subcommittee, which can be easily done on myisth.org. We're always looking for people that are interested in helping us with our endeavors to learn more. And with that, I would like to thank you very much for your attention.
Thank you both very, very much for these really, really great presentations. So we do have about 10 minutes left on the hour, and there are a few questions in the question and answer section that I'll go over with you guys. I think you can see them as well. So Dr. Khan, on behalf of the CTAC thrombosis team, is asking, so if patients with cirrhosis and varices don't bleed more on versus off anticoagulants, as per Dr. Lisman, I think this is referring to your last slide. Why does ISTH guidance recommend screening for varices before starting anticoagulation in cirrhosis patients with VTE?
Yeah, this is a great question. And so I think I can give two answers. So one is that the evidence that patients don't bleed more on anticoagulants is based on one retrospective study. So the data are not very firm. And if it is true, what we're doing is defensive medicine. And this is something that we struggle with in this entire field. And so why can't we get people to stop giving prophylactic FFPs and prophylactic platelets prior to procedures? It's just because there's this sense of, these patients might bleed, so we need to do something. And I think this also holds true for taking care of varices before initiating anticoagulation. We are afraid that these patients may bleed more, and the data is not firm enough to be sure. So I think that's why we advise this, and that is why we practice like we practice.
Okay, perfect. And so there's a second question here from Dr. Yan Xu from here in Ottawa. So again, to Dr. Lisman, ISTH guideline suggests not checking fibrinogen levels based on a low likelihood of less than 1 gram per liter in the non-critically ill setting. Would this be for both procedures with moderate and high risks of bleeding? So I think that's the first question. And then there's a second question. So would you suggest replacing with concentrates prior to procedures with elevated bleeding risk for patients with known hypofibrinogenemia in the context of liver disease below that threshold for fibrinogen?
Yeah, again, a great question. And again, we don't really know the answer. There is one, again, retrospective study that has looked at the effects of either fibrinogen concentrate or cryoprecipitate suppletion of critically ill patients with cirrhosis in the context of procedures. That study showed no effect whatsoever of improving fibrinogen levels prior to procedures. So this suggests that although low fibrinogen may signal increased risk of bleeding, improving fibrinogen levels does not help. We know that this is true in other contexts outside of liver disease. So I don't think there is a firm rationale to normalize fibrinogen levels, particularly not if they are above 1. What you should do if they are below 1, so there's two options. Either you you give prophylaxis. I don't think there's any major harm associated with fibrinogen prophylaxis, or you wait and see and you give fibrinogen once bleeding occurs. And that's something that we have learned for a long time in liver transplant surgery. So there's many centers that accept very low fibrinogen levels. So we accept fibrinogen levels of 0.5 prior to transplant, and we don't prophylax, and we wait. And if there's active bleeding and fibrinogen levels is still that low, then we go in and give fibrinogen concentrate. So this depends, of course, on the site of the bleeding, whether you have access or not, whether you have other options to stop the bleed. But I don't think so. This is a long answer. I don't think there's firm evidence to suggest that you should prophylax even in patients that have expected fibrinogen levels below 1.
Okay, fantastic. Thank you. And then one question to Dr. Carlin. Any recommendation for fibrinogen threshold for patients meeting the indication for anticoagulation? So not necessarily in the context of a procedure, but just starting a patient with cirrhosis, I guess, on anticoagulation.
Yeah, it's a good question. I have to admit I don't have anything more to add beyond what Dr. Listman already said. I don't think I could give a specific recommendation as far as that.
Yeah, I know that I've looked into this a few times for my own patients, and I've never found any great data to suggest necessarily a higher threshold, but it's something that I've wondered about, and I know my colleagues have wondered about as well. Not just in the context of cirrhosis, but and maybe I'll finish just with one more forward-looking question, maybe more directed to Dr. Lisman. As I mentioned, I'm a big fan of your work on thrombin generation and specifically evaluating anti-thrombotic efficacy in the context of cirrhosis. And I was wondering, as I was reading over the guidance document again and these various studies you've done, do you think that we're ever going to get to a point? I mean, liver disease and cirrhosis is such a dynamic disease, right? Child-Pugh A compared to Child-Pugh C, it's not really the same disease, and there's so many moving parts. There's the platelet component, there's alterations in fibrinolysis, there's the coagulation changes, and there's the anatomic changes as well. So I guess I'm just wondering, do you think we're ever going to get to a point where we can maybe even develop a precision medicine or a tailored approach to these patients? And do you think maybe that's a more viable strategy than trying to enroll these patients in clinical trials, because they do tend to be very hard to study?
Yeah, so yeah, of course, that's been the problem in this field. So these patients have been enrolled in more important studies on hepatitis B, on NASH. So there's very little room left for studies on the complication of the disease, not the disease itself, which we're talking about. So yes, you might be right. We may never get high quality evidence. So what's then the alternative? And I think my answer would be twofold. So one, I think we should stop doing things that we think are not helpful. And this includes prophylaxis of FFP and platelets, for example. And so we will never get high quality evidence that we really shouldn't do it. But I think we have quite a good idea that it may not help, but it will do harm. Can we use laboratory tests or otherwise, or a combination of clinical parameters and laboratory tests to tell us what to do? Perhaps, but also studies that would show that are very difficult. We have planned but never executed studies like this, to see if we can, use laboratory tests to predict who will bleed and who will benefit from prophylaxis. These are also very large studies, and as you say, because these patients are so complex, in terms of the spectrum of disease, in terms of the reasons for bleeding. So in the end, I think using common sense and a case-by-case approach will likely be the best option that we may get. I'm less optimistic than you, I think, in using laboratory tests for steering clinical management. I think we have learned that laboratory tests predict very little.
Yeah, maybe good in theory, but in practice, it's always challenging to make things work the way you want them to work. I do think we have to leave it there in terms of questions. Caleb, I don't know if there's that last summary slide, but I'll start by saying thank you so much to Drs. Carlin and Dr. Lisman for this really great presentation. Just to highlight again that this guidance document is really fantastic, not just in terms of the guidance statements, but it's a really great review of the literature, both from an epidemiological point of view, but also a pathophysiology point of view. So another reminder that the recordings are available on the website shortly, and please complete your seminar evaluation. And the next seminar has actually already been scheduled for December 12th. It will be Dr. Hugo Tenkate, also from the Netherlands, who will be presenting on the winding road to personalized antithrombotic therapy, a translational perspective. So again, thank you to our presenters and thank you to our attendees.